Welcome back to CLOT Conversations, the podcast where we cover some of the latest work in the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by our co-hosts, Dr. Jamil Abdul-Rahman from Toronto General Hospital and Dr. Maha Othman from Queen's University in Kingston. Get ready for another interesting discussion. Thanks for being a listener.
In this episode, we'll be discussing a publication covering recent research from the Lancet entitled Efficacy and Safety of RGN-9933 and RGN-7508 for preventing post-operative venous thromboembolism, ROXI-VTE I and ROXI-VTE II, two randomized open-label phase 2 trials. We're pleased to have lead author today join us, Dr. Jeff Weitz.
Dr. Weitz is a professor of medicine and biochemistry and biomedical sciences at McMaster University, executive director of the Thrombosis and Atherosclerosis Research Institute, and past president of the International Society on Thrombosis and Hemostasis. Dr. Weitz focuses his clinical practice on patients with thrombotic disorders. His research spans the spectrum from basic sciences in the biochemistry of blood coagulation and fibrinolysis to animal models of thrombosis and onto the clinical trials of antithrombotic therapy. The breadth of his work is highlighted by his over 660 publications. The recipient of numerous awards, Dr. Weitz was appointed as an officer of the Order of Canada and is a fellow of the Royal Society of Canada and Canadian Academy of Health Sciences and was elected to the American Society of Clinical Investigation and the Association of American Physicians. It is great to have you here, Dr. Weitz, and thank you for participating in our podcast. Let's get started.
My pleasure.
Right. So I'll ask the first question. Can you give us an overview of why factor XI inhibitors are now being studied, and what is their potential benefit over the current DOACs?
Great question. Well, as you know, the DOACs have taken over from warfarin for many indications, especially the treatment of venous thromboembolism in most patients and stroke prevention and atrial fibrillation. But still, bleeding is the major concern, and the rates of clinically relevant non-major bleeding and major bleeding can be as high as 20% per year in some patients, particularly our elderly patients with atrial fibrillation. And the bleeding or the fear of bleeding leads to the underuse of anticoagulants for stroke prevention. We know even the latest registry data suggests that at least 40% of patients who are eligible for anticoagulation don't get it. And a lot of that's because of bleeding or the fear of bleeding. So we need to do better. We need safer anticoagulants, and that's where factor XI inhibitors have the potential to be safer than what's currently available.
Right. So there are two factor XI inhibitors that were studied in this publication, REGN-9933 and RGN-7508. Would you be able to share with us how do they work and how are they different from each other?
The two antibodies, these are both human monoclonal antibodies that bind to factor XI, but they bind to distinct domains. The 9933 binds to the APL2 domain and blocks factor XI activation by factor XIIa, but not factor XI activation by thrombin. And the 7508 antibody binds to the catalytic domain, and it blocks factor XI activation by both factor XIIa and by thrombin, and blocks factor XIa activity. So two antibodies against factor XI, but two distinct mechanisms of action. And so the study that we did was driven by the hypothesis that factor XI is important in the pathogenesis of post-operative venous thromboembolism. We know that because of the results of other studies with factor XI inhibitors. But what we didn't know is how important is factor XI activation by factor XIIa to post-operative venous thromboembolism. And that's what the two studies could tell us because of the distinct mechanisms of action of the two antibodies.
Excellent. Thank you.
Okay, very interesting. So ROXI-VTE I and ROXI-VTE II are both open-label RCT in patients over 50 undergoing knee arthroplasty. So ROXI-VTE I compared REGN-9933 to proph-dose enoxaparin and proph-dose apixaban, whereas ROXI-VTE II compared REGN-7508 to proph-dose enoxaparin. Why was apixaban not included as a comparator in ROXI-VTE II?
Well, apixaban was included as a comparator in ROXI-VTE I simply for descriptive purposes. It was an exploratory comparator. The real comparator was the enoxaparin, which was used in both studies. But we also wanted to get some information about how these antibodies might compare with an oral factor Xa inhibitor. So both of these studies are small phase 2 studies. They're really proof of concept studies to get an idea of how efficacious and how safe these antibodies are. And they're really not designed to test these antibodies in a phase 3 style against either of the comparators. But we just included apixaban in the ROXI 1 because we wanted to get some exploratory information about how the antibodies compared. And a Bayesian approach was used for the data analysis so that we could borrow half of the enoxaparin patients from ROXI 1 and include them in the analysis for ROXI-VTE II. And we could also make cross-study comparisons with all the limitations of doing so.
Mm-hmm. So, as you just verified, these are phase 2 trials. It would be useful for our audience to maybe clarify how do phase 2 studies differ from phase 3 studies?
Well, phase 2 studies are the first studies to compare a new drug with the current standard of care and to get an idea of, often they're used for dose finding to determine what the optimal dose might be of the new drug to carry forward into phase 3. The thing about these factor 11 antibodies, they're kind of all on or all off. In other words, you pretty much have to saturate factor 11 with the antibody so that that factor 11 then circulates with the antibody bound to it, and that then blocks its activation by factor 12A in the case of the 9933, or its activation by 12A or thrombin in the case of 7508. So these studies were really done just as a proof of concept to show how well the antibodies work and then to set things up for phase 3 studies, which are done in a larger number of patients and often with a more clinically relevant outcome than the venography that was used in these phase 2 studies.
Mm-hmm.
Okay, so let's move on to the results. So in both studies, what did you find regarding the primary endpoint of objectively confirmed VTE up to day 12?
Well, I think the best way to summarize it is that the 9933 had antithrombotic activity similar to that of enoxaparin. The point estimate was a little bit lower. It wasn't significantly better, but its efficacy was similar to that of enoxaparin, whereas the 7508 was superior to enoxaparin, a greater reduction in the risk of postoperative VTE, and it had activity, again, cross-study comparison, but it had activity similar to that of apixaban. So that gives us a lot of information. I think the first point is that the fact that 9933 has activity like that of enoxaparin was very interesting to me because it says then that factor 12A activation of factor 11 must contribute to postoperative VTE. And that raises the question as to, what is activating factor 12 so that the 12A could then be activating clotting through that intrinsic pathway. And then, of course, the results with the 7508 are similar to results with other antibodies, like, for example, abelacimab, which also binds to the catalytic domain and was shown previously to be more effective than enoxaparin for prevention of postoperative VTE and similar safety and better safety or similar safety. So in this study, though, I think the novel finding was the results with the 9933 because I didn't know whether it was going to work at all. And
Mhm.
I was pleasantly surprised that it actually had activity.
Right. So let's talk a little bit about the mandatory venography of the operated leg to screen for VTE. So the vast majority of VTE in these studies were asymptomatic distal DVTs. Does this change how we interpret the results?
No, I mean, in these phase 2 studies, that's a nice thing about this orthopedic model, I call it. It's a model that can be used for dose finding with new anticoagulants because by doing the venogram, you can get an objective measure of the incidence of thrombosis with different doses of the anticoagulant. And because it's done in patients who've just undergone surgery, you can also get an indication of safety because they've just had surgery. If they're going to bleed because has a hemorrhagic potential, then they'll bleed from the operative site. So it's a great model to get information in relatively small numbers of patients about the efficacy with different doses. I agree that the clinical relevance of some of these small DVTs in the calf is uncertain. And but that's not the point. The point is really to get information for dose finding purposes.
Right.
Hey, yes, let's talk a bit more about safety. So in both studies, what did you find regarding the main safety outcome of composite major and clinically relevant non-major bleeding?
Well, yeah, I mean there were no major or clinically relevant non-major bleeds in either of the studies. So that was a little surprising. And it's something that we've been seeing as we've done more and more of these studies with the factor 11 inhibitors over the last few years is that the surgeons are getting better and better at doing the surgery without much bleeding. And so the value of this model for assessing safety is open to question. But again, we're dealing with very safe anticoagulants. Perhaps if we were testing something of uncertain safety, we might still see more bleeding. But in these studies, we really can't get much information about safety. And you might imagine that going into the studies, the hypothesis was that 9933 might be safer than 7508 because it blocks 12A activation of 11, but leaves the thrombin pathway intact. So that gives you kind of an escape route, whereas the other one blocks everything. But we didn't see any difference in bleeding. Both were not associated with any bleeding. So we can't get much information about the relative safety of these from these studies. We'll have to get more information in ongoing phase 2 and phase 3 studies.
Hmm. So apart from bleeding, were there any other concerning adverse events noted from either the 9933 or the 7508?
No, there really weren't that, if we look at adverse events, more importantly, serious adverse events, there were no real difference. And any serious adverse events weren't related to the drug, things like cholecystitis, for example, or something like that. And there were no infusion reactions that developed. Remember, it's a single intravenous dose of these antibodies versus daily dosing of either the enoxaparin or the apixaban.
Right.
Okay, so what conclusions can we draw from this study, and what's next for these drugs? Maybe you could tell us a bit about the ROXI-Apex and ROXI-Aspirin studies coming up.
Right. Well, I think these studies set the stage for further trials of these two antibodies. To me, the next study that we'll probably report out will be not the ones that you've mentioned, which are phase 3 studies, but a phase 2 study called ROXI-CATH. And that's a study in patients with PICC lines where the subjects are given an intravenous injection through the catheter of either 9933 or 7508 or placebo. And then the catheter thrombosis is detected by either symptomatic upper extremity DVT or by ultrasound of the upper extremity done up to 1 month. And why I think that study is so important is if there is a place where the 9933 could shine, it's in device-associated clotting because that's triggered through factor 12 activation and factor 12A. So I think that ROXI-CATH study will tell us whether the added 11 activation inhibition of thrombin activation, whether that adds anything to just 12A inhibition when it comes to device-associated clotting. And I'll be really interested to see that because it's still possible that although devices trigger clotting through the activation of factor 12, there still could be a play of some tissue factor inducing thrombin and getting back activation of factor 11. So I think the ROXI-CATH will tell us that. And then there are 2 phase 3 studies in orthopedics patients that are kind of following up on the results, the direct results of the ROXI-VTE I and II studies, and that's the studies, as you said. One is, I think, the more interesting one to me is the study comparing aspirin versus a single injection of 7508, so the more potent. So it's an idea here. We know that EPCAT-3 is comparing aspirin versus 5 days of rivaroxaban followed by aspirin, and the results will probably read out, probably sometime next year. But this is the next step because when you talk to orthopedic surgeons, they like the concept of a IV injection, a one and done approach to prophylaxis, and versus having to take aspirin every day and people forgetting it or not taking it or whatever. So then the other study is a venographic endpoint, again, with all the limitations of venography as the outcome measure, but that one will compare the antibody with both enoxaparin and with apixaban, much like ROXI-VTE I did. The problem I have with that is that, as you know, at least in Canada, we rarely use apixaban for thromboprophylaxis after orthopedic surgery. If we are using a DOAC, we tend to use once-a-day rivaroxaban in prophylactic doses. But nonetheless, I think those 2 studies will tell us something. There's also a phase 2 study that started in atrial fibrillation where patients are randomized to get every 2-week injections of either 7508 or 9933 versus apixaban. And it's a Pacific AF-like study, a small study. It's mostly looking at the safety of the 2 antibodies in the AF population.
Right. Well, Dr. Weitz, you've given us very comprehensive coverage of this Lancet paper, and I was wondering if there's anything else that we haven't discussed that you would like to add?
Well, just that, these aren't the only factor 11 inhibitors that are out there. We've just seen a press release from Bayer about the oceanic stroke study, suggesting that it met its efficacy and safety outcomes. That's exciting because we may now have a new option for secondary stroke prevention in patients with non-cardioembolic ischemic stroke or high-risk TIA. We're waiting anxiously for the Librexia stroke study. I think the fact that the oceanic stroke study was positive bodes well for the Librexia stroke study. We've also had the disappointing news about the Librexia ACS study, which was stopped early because of potential futility without a sufficient reduction in the risk of recurrent ischemia with milvexian versus placebo on top of antiplatelet therapy. Why did the stroke study succeed and the ACS study not? I think we'll need to see more details about both of those studies to better understand it.
Right. Well, thank you so much.
You're very welcome. Pleasure talking to you.
Thank you all for the great discussion, and for our listeners to read the full publication in the Lancet. The link is in the program notes. And thank you to our audience for joining us on CLOT Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. Want to stay up to date on the latest in thrombosis? Hit that follow button so you never miss an episode. And don't forget to visit Thrombosis Canada for a wealth of resources, including clinical tools, patient guides, and information on our upcoming programs. Your support matters, so please consider donating to Thrombosis Canada to help us continue to educate and increase awareness. Thank you, everybody. That was a great interview. Thank you so much, Jeff.
No problem.
Really interesting.
My pleasure. My pleasure.
Very useful.
I saw a headline this past weekend about a study that showed that patients that had ablation didn't need to have thromboprophylaxis for AF. Did you see that?
I did. It's suggesting that successful ablation and then, cessation of the AF, those patients don't need to stay on an anticoagulant. We don't really know. The secret is determining whether they've had a successful ablation or not. So that's the big question. How do you make sure that their AF is gone when they have paroxysmal AF? How long do you wait? How long do you record to be sure that there's no further episodes of AF? So I think that's something we're going to hear more about. I think the other thing we're going to hear more about as time goes on is in patients who have atrial fibrillation are at high risk for stroke, the concomitant use of anticoagulants, DOACs, probably like apixaban, plus some left atrial appendage occlusion or removal or something. So I think that too might be something we'll learn more about over the next few years. So exciting times. There's always something new happening.
Mm-hmm. There sure is. It's great, and we appreciate you sharing this new news with our audience. And I will be getting it posted as soon as I can.
No problem. Thank you very much for inviting me. It's been a pleasure to see you too. Bye-bye.
Bye-bye.